There we go. Got to unmute myself there. So I think we are in business for 8, 12, 16, 17. I do have this recording again so that if there's someone who isn't able to sign on, there was a bit of a problem last class period. There were 3 students who said they couldn't sign on, that they got a message that there was another meeting in progress or something. I'm just going to wait a couple more minutes to see if everyone gets on. Okay. So there are 20 students in the class, and I'm seeing 4, 8, 12, 16, 17, 18, 19 of us total, minus me is 18, so we're still a couple short. I'm seeing Shannon, you got signed on, it looks like.
Yep, no problems this time. So
excellent. Okay, we are back, and it's March 24, which this is totally irrelevant to you, but it's my mother's birthday, so I'm going to be calling her later today and wishing her happy birthday. And we've got 20 people on the call, which minus me is 19, so we're pretty much all here. And I'm seeing some of you have your screens on, some of you don't. It really doesn't matter at this point, I guess. Out of curiosity, I'm wondering, do any of you know anyone or have heard of any family members or anything that that have been diagnosed as positive? Does it come close to home for anyone yet? Yeah, me neither. Haven't encountered any yet. So you read these predictions of, like, in even just over the next couple of weeks, I guess it could get, if it follows the epidemic curve, it could actually accelerate quite a bit, and they're expecting a lot more cases in New York. I know, actually I talked with one of my cousins yesterday who has a niece who is in New York City, niece, and I think her husband, so his nephew through marriage, is either doing a residency or something in one of the New York City, one of the Manhattan hospitals, and the report is, yeah, they're running really short of beds and supplies, so some parts of the country are really getting slammed with that. So what I want to do today is we're going to finish talking up about the epidemiological basis of disease. We are going to look at another paper, this one from China, again, just seeing what's out there in terms of current epidemiology. So maybe I'll do that first. Here we go. Okay. Here we go. So found this intriguing, but so this is actually no, I don't read Chinese, but when I press the magical little translate button, it suddenly is comprehensible here. So this is actually analysis of epidemiological characteristics of the coronavirus from a Chinese medical journal. So I thought that was interesting to go to the source, and as I scanned through it, it seemed more or less comprehensible through the Google Translate. So I wanted to point out a few things to you that's particularly tying into some things that we've talked about with this class. So it gives a little bit of background. Unexplained mass pneumonia in Wuhan, of course. The Chinese CDC sent a rapid response. On January 1st, they closed the seafood market, disinfected it. And their research design was to describe and analyze the epidemiological characteristics of all COVID-19 cases reported in mainland China up to February 11, 2020. They used a cross-sectional design. That should sound familiar. And let's continue here. They talk about the statistics. Some of the charts didn't totally translate. You can see, I guess they're images, so that's not gonna mess us up too much. So you can see as you go along, let's see, where did I want to get to? Actually, I wanted to start at the, okay, so for starters, just to point out some of the details. So here they're talking about the cases. A total of 72,000 cases were reported. 44,000 were confirmed through with, however they ended up conferring them. 22% were suspected, and 1% were 1.2% were asymptomatic. Most of them were between 30 and 69 years old. A little bit more than half were male. Hubei province was the most number of them. And look at this, and this is consistent with what we've seen elsewhere. 80%, 81% of the cases were mild. So this, again, is not a disease that is hammering people. Yes, some people are getting it seriously, but the majority of them are counted as being mild. Looking here then, and this should sound familiar as well, because they're talking about case fatalities. The crude case fatality rate was 2.3%. Okay, not enormous, but certainly higher than the flu. Our case fatality rate of 0.015 per 10 person days, which means that the average risk of death per person observed for 10 days was 0.0, so less than, or you could say 1.5%. The highest case fatality was in the group 80 and over. You'll recall that when we looked at Italy, again, it was people 70 and 80 that were the most affected. The crude case fatality rate was 2.8% for men and 1.7% for women, so significantly higher for men than women. By occupation, retirees. Then they look at age and sex distribution, spatiotemporal distribution. So this isn't translating, but you can see over time how it's spread across the country, throughout the country, from originating from this original area there. Let me see. Lost it here for a moment. Here we go, translation it again. Try that once more. So that was most of it, but I wanted to, let's see, we'll finish up just looking at the abstract. The epidemic curve showed a peak around January 23 to 26, with a decline of number of cases. It is affecting medical workers, 5 died. A crude case fatality, we mentioned there, of 0.3%. So it spread rapidly. It reached the first epidemic peak in January 24 to 26. The single day outbreak was extremely high on February 1st, and then it's been gradually decreasing. So it looks like the worst may be over in China, although some people are still saying, well, maybe they're just not reporting it. Maybe they're fudging the numbers to make it look good. There could be political pressure to do that. So we'll see. We'll see. Moving on, I want to look at then continue to talk about what we talked about on last Thursday. You'll remember what I'm doing is making the case, making my best case that epidemiology is necessary for clinical medicine. That in order, particularly for chronic diseases where you've got a continuum, everyone has blood pressure, everyone has blood sugar, everyone has a level of thyroid, everyone has a level of cholesterol, of triglycerides. And when you've got that continuum, how do we know as where to say, this point above that is too high, below that is too low? How do we define a disease on these continuums, like blood glucose? And so my thesis, my point to you is that it is epidemiology looking at population-wide associations between these variables. For example, looking on the page here, you should be seeing retinopathy and diabetes. So we're looking at hemoglobin A1C. Hemoglobin A1C, of course, is a measure of glucose in the blood. And we can start to see, okay, when does retinopathy start occurring? When does nephropathy, when does kidney disease start occurring? And that then allows specialists, allows experts to make those cut points, determine those cut points, and say, yeah, if your blood pressure is higher than 120/80, we start to see complications. Maybe there's higher rates of stroke, maybe there's higher rates of cardiovascular disease, whatever. So it's the associations between the clinical variable and disease outcomes. And that is something that in the absence of public health, in the absence of epidemiology, clinicians wouldn't have. 200 years ago, even if they were measuring blood pressure, did they have the data to be able to say what was too high and what was too low? No. And so that's the major contribution for epidemiology to clinical medicine. And so we talked about it in terms of retinopathy being sort of the early indicator for diabetes. We looked at cardiovascular disease. I'm just quickly reviewing here. We looked at BMI and various factors, how they're associated with BMI. Not all. For example, triglycerides, high LDL cholesterol. Triglycerides aren't strongly associated with BMI, but many of these other things like hypertension, like diabetes are. And we made the intriguing observation that the BMI of somewhere around 25 seems to just fall out of plotting the data. So we can look at BMI and deaths, and in men it's maybe a little bit higher than 25. Women, it's right around 25. And then we looked at diabetes, and same thing happened. Diabetes started to increase significantly at a BMI somewhat, a little bit over 25 there. So that's where these numbers come from. What I want to do then is finish up talking about this a little bit more, and then we'll talk about the assignment. There's a short video clip that I want us to watch that illustrates some of these issues and illustrates how medical professionals grapple with and determine what constitutes diabetes, what constitutes high blood pressure, that type of thing. Okay? So we ended up, I believe, on this slide here last Thursday where we were looking at hemoglobin A1C. Again, that's an alternate measure of blood glucose. And you can see that as hemoglobin A1C increases there on the x-axis, that the risk of these various complications also increases. Some more strongly than other. Retinopathy increases first and quickest. Kidney disease, nephropathy, less so, and neuropathy and microalbuminuria, less so, but still there's that strong association. Okay, so let's summarize then. This is looking at, this graph's a little bit hard to read, but you can see the bottom where the cursor is here. I'm moving along. You've got hemoglobin A1C concentration, again, 5, 6, 7, 8, 9, 10, 5, 6, 7, 8, 9, 10. And those x-axis scales continue above here as well. So we can see that for fatal and non-fatal myocardial infarction, as hemoglobin A1C or blood glucose increases, the hazard ratio, which again we interpret similar to relative risk, increases. Okay, so that a person with a hemoglobin A1C of 10, and it looks like they've got a log scale here of some sort. It's hard to read it exactly, but there is a substantial increase. So that's looking for non-fatal and fatal heart attack, fatal and non-fatal stroke. Hemoglobin A1C goes up, risk of stroke goes up. Microvascular endpoints, I'd actually have to dig in the paper. I'm not exactly sure what that is. Cataracts, we haven't even talked about cataracts, but cataracts, the clouding of the eye requiring surgery, as blood glucose goes up, your chance for cataracts increases. Your chance of amputation increases. Your hazard, your risk of heart failure increases. Okay, so all those associated with that elevated glucose in the blood. Okay, since I've talked about diabetes here, just want to specify it a bit more. Some of you, depending on your background, will be familiar with this. So this is looking at different definitions, definitions of diabetes. It can be 7.0 millimoles per liter or 126 milligrams per deciliter, or then we talked about earlier, hemoglobin A1C, HbA1c. If it's above 6.5% on 2 tests considered diabetes, normal is less than 5.7%. We looked at that when we were talking about Mrs. Smith. And then you've got this area of prediabetes, 5.7 to 6.4. And so and just to talk about it a little bit more, so hemoglobin A1c basically is a way of capturing the average blood glucose over a period of time. So you don't need to be fasting when you take a hemoglobin A1c test. You could have just had a Coke or an ice cream cone, whatever. That doesn't matter, because what it's doing is measuring how much glucose is attached to the hemoglobin on the blood cells. So healthy red blood cells have some glucose stuck to them. If your average blood glucose level is elevated, just because of the higher concentration of glucose, there's going to be more glucose attached to the blood cell. Blood cell lasts roughly 120 days. You may remember that from anatomy class, A&P class. I believe it's around 120 anyhow. And so depending on how much glucose is stuck to the blood cell, that will give an overall indicator of how much glucose has been in the blood over time. If your average glucose is high, there's going to be more stuck to the blood cells. If it's lower or in a healthy range, there's going to be less stuck to the blood cells. So it's not a snapshot in time like taking your fasting plasma glucose. It's an average over the lifespan of that blood cell. So it can work, both of them are used for diagnostic purposes, both the fasting plasma glucose and the hemoglobin A1c. And as I say, the biggest advantage is for hemoglobin A1c, you don't need to be fasting in order to take it. If any of you've done clinical work, done blood draws, I have never done blood draws, but we were working with diabetes prevention in Pittsburgh, and sometimes people would come in for the blood test and for the fasting blood test, and they'd had coffee with milk or they'd had coffee with sugar, they forgot. Okay, well, got to come back because the plasma glucose is not going to be fasting. But the hemoglobin A1c would be just fine. Okay, so that's a little bonus for those of you, so you'll perhaps know a little bit more about hemoglobin A1c. Okay, let's look at another example. So we've talked about diabetes in terms of heart attacks, strokes, cataracts, amputations, retinopathy. We've talked about it in terms, and here we go. So the next one is, I'm going to ask you, the collective you, the 19 or 20 of you that are out there listening, are diabetes or prediabetes associated with mild cognitive impairment or dementia? So take a look at that, and I'll be waiting for someone to take a stab at interpreting it. Any takers on that? Can you make a case that diabetes or prediabetes are associated with cognitive impairment or dementia? Um, Broder, are you seeing anything of interest there? What are you seeing? What can you tell us?
I would say that there is a correlation just because when we look at the confidence intervals for each one, that first number before the parentheses, I don't know what that's called, but it's all included in the confidence intervals.
Mm-hmm. Okay, so can you point to something specific and say, yes, based on these numbers, you're making the case that there is an association between the two? Anna, do you have any insights? I'm tempted to pick on people that I can actually see, so some of you are at higher risk than others.
Can you repeat the question again?
Yeah, and so do you have any insights, or can you make a case that diabetes or prediabetes is associated with mild cognitive impairment, looking at that table?
I was looking at it, and is it that if it includes one, it doesn't support it, or
Right?
for the confidence interval?
Yeah, if the confidence interval doesn't include one. So what I'd say is focus on the hazard, the HR, the hazard ratio, which we interpret like a relative risk.
Okay, then I would say that it supports that dementia is associated with diabetes over MCI.
Mm-hmm. Okay, so for example, we could look here. So dementia. They give people that don't have diabetes a value of 1, reading over here. And if they then compare people who don't have diabetes with people who have diabetes and prediabetes, so they're combining these two categories, and you can see the value there is 1.82. So that means compared to those who don't have diabetes, those with diabetes and prediabetes have an 82% greater risk of dementia. Okay, does that make sense? And if they look at prediabetes by itself, people with prediabetes, so this isn't a formal diagnosis of diabetes, they have still, 64% greater risk of dementia compared to the people who don't have diabetes. And then lastly, if you look at people with diabetes, they have 110 or 2.1 times greater hazard of dementia compared to people who don't have diabetes. Okay, so what that tells me, and you'll see here that for the mild cognitive impairment, the numbers aren't statistically significant. But when they actually, however they're defining dementia, and that would be based on clinical criteria, that diabetes is associated with dementia. And I'll say again, for those of you who might be working clinically or interested in health, community health, the one to me that's most scary is this one for prediabetes. So people with prediabetes, oh, my blood sugar is a little bit high, maybe I need to lose some weight, maybe I need to be a bit more active, but they are still at substantially elevated risk for dementia, even without that formal diagnosis of diabetes. So I guess my point to you is it just illustrates the seriousness of elevated blood sugar. And so we've talked about it in terms of dementia. We've talked about it in terms of retinopathy. It's just a terrible, and yet from a public health perspective, since it's largely preventable through nutrition, many of you have been in nutrition class, through nutrition and physical activity, the encouraging thing is that it's largely preventable, type 2 diabetes, or reversible, so that people who maybe have type 2 diabetes, who are experiencing the impact of type 2 diabetes on their eyes, on their kidneys, on their brain, pretty much all body systems, that can be reversed. Weight loss, physical activity, improved diet. So it's encouraging in that sense, but it's also, I'd argue, tragic that so many people have diabetes when it is preventable, it is treatable, it is reversible. So that's my little sort of public health plug for those of you who will be working with patients in any context, whether it is a PT or an OT or whatever, even if you're not directly working with them in terms of their diet, you can still nudge them towards positive lifestyle changes that will reduce that debilitating impact of diabetes. And here we're seeing it in terms of dementia. So does that make sense? Talking through this table, how to read it, how to interpret it. So here the IR, that's the incidence rate. That's, from my perspective at least, the hazard ratios are where it really comes together and where we can really make the case, hey, they're at elevated risk. Okay, does that make sense? Any questions on that?
I had a quick question.
Okay.
So,
Yeah, Sydney,
you
right?
talked about yes. You talked about lifestyle changes for diabetes. Are there any lifestyle changes you can make for dementia?
It's going to be a lot of the same factors, because if diabetes is related to dementia, and we know that diabetes is related to lifestyle, I don't have the data in front of me, but the same things are going to happen. Physical activity, it has been demonstrated independent of its effect on diabetes. Physical activity has been demonstrated to help delay the onset of dementia or slow its progression. So basically anything that you can do. Well, and let's actually step back. Why, based on your understanding of anatomy, of physiology, why might diabetes affect the brain? What mechanism might be at play there? Can I pick on Sydney? How might that work?
Um, I'm not sure. Maybe I know like certain like parts of the brain are more involved with memory than others.
Mm-hmm.
So I guess physical activity and nutrition would help to keep those certain parts of the brain healthier.
Mm-hmm. And that's true in a general sense, but let's even think specifically. The brain is depending on blood flow for the exchange of nutrients, of gases, in order to nourish those brain cells. And we know that elevated glucose causes damage to the small blood vessels in the eye. That's what the retinopathy is. And so we would expect that's going to also be affecting the capillaries in the brain. Okay, so it's basically limiting the brain to get the effective and efficient supply of nutrients and exchange of gases. And so it actually shouldn't be surprising that we do see this association between blood glucose and, in this case, dementia. So, but to just sort of to finalize or summarize your question there, Sydney, yeah, anything that makes the body overall healthier is going to help maintain the health of the brain. Yes, there are genetic factors involved, but if a person's body is healthy, their brain is going to be healthy, and that's going to mean that there's less of a chance of them getting dementia, although, you know, it still can happen. There's no doubt about it, but we can reduce the risk. So thanks for asking that question. Let's move on then and look at some other relationships. Again, relationships between clinical values. In this case here, now we're looking at diastolic blood pressure. That's the heart at rest. And relative risk of stroke. Okay, so this is the lower number on your blood pressure. So when we say 120 over 80, so the 80 is going to be right about there. And you can see that the relative risk of stroke, a person whose diastolic blood pressure is at 91, if the diastolic blood pressure instead is at 84, you can see there's, you know, maybe it's at 0.6 or so, and that would mean about a 40% reduction in the risk of stroke, just taking your blood pressure down from 91 to 84. And if you take it from 91 down to 76, it looks like, you know, somewhere 35, 36%. So you could say if this is 100% and this is 36%, you could say that taking the diastolic blood pressure down from 91 to 76 reduces the risk of stroke by about 64%, 64, 65%, by about 2/3 would be another way of saying it. Does it make sense? Do you see where I'm getting these numbers? So 91, we give a value of 1 or 100%. 76, I'm just reading off the y-axis, is somewhere around, you know, 35 or something, 40. So you could say roughly from 100% down to 36 or 40% is somewhere around a 60%, 65% reduction. Okay, does that make sense? Hope so. So that's looking at blood pressure and relative risk of stroke. This is looking at diastolic blood pressure and relative risk of coronary heart disease. And we see a very similar relationship. Again, they're giving the value of around 91, a value of 100%. So blood pressure, diastolic blood pressure of 91, giving it a value of 100%, and a blood pressure of 76 is down a little bit less than 50. So you could say there's a greater than 50% reduction in the risk of coronary heart disease if the diastolic blood pressure is at 76 as opposed to 91. Okay, and I'm looking at it the other way. So a person whose blood pressure is 105, again, that's the resting blood pressure. Their risk compared to a person whose diastolic is at 91, their risk is almost 4 times greater. You know, 3.5 times greater, something like that. And so that's why, from a risk perspective, from the danger perspective, actually having an elevated diastolic blood pressure is even worse than having an elevated systolic blood pressure, because what that means is even when your heart is resting for that fraction of a second, there's still a lot of pressure in the blood vessels. When the heart is contracting, yeah, the pressure goes shooting up, and if it goes shooting up too high, that's also bad. But if it's high even at rest, that exacerbates or elevates the risk of many of these cardiovascular endpoints. Okay, any questions on this figure that we're looking at then? You could explain it, you understand what's happening there. Okay, we will look a little bit further. So this was looking at hypertension and stroke. Here we're looking at triglycerides and stroke. We haven't talked about triglycerides much yet, so that's basically the fat in your bloodstream. Those of you who've taken chemistry, you know that you've got the glycerol and the 3 fatty acids, the so-called triglyceride. So what are we talking about here? How are triglycerides related to coronary heart disease? I'll just read through the title. The relative odds of coronary heart disease among patients who had log, so they've taken the log of the triglycerides, in the top third compared to those who had them in the bottom third. So they're dividing it into tertiles, into 3 groups. Often they'll put it into quintiles, 5 groups, quartiles, 4 groups. This case, they're dividing it into 3 groups. So they're looking at the highest third versus the lowest third for triglycerides. And here we've got 2 different studies. The Reykjavik study. Anyone know your trivia? What's Reykjavik?
It's
Capital.
Iceland.
What's that?
Iceland.
Yes, capital city of Iceland. Excellent. And then Epic Norfolk. I think this is. I'm not positive on that, where this one is. This could probably in the UK, but I'm not positive. I didn't look that up. So I want you collectively to look at, let's first of all look at the Reykjavik study and the association between triglycerides and coronary heart disease. I'll wait for a volunteer to take a stab at the association between high triglycerides, the top third versus the bottom third in the Reykjavik study. So look at it for a few minutes and be brave and take a stab at it, or I'll call on someone. Let's see, Emily, what are you seeing?
So it looks like I'm looking at the under the all individuals, the adjusted for age, gender, period, the smoking, and all other established.
Okay, so right here.
Mm-hmm.
Yeah.
So it looks like for that group that so I'm trying to think trying to remember how you phrase this. Well, it's a 43% more likely. Sorry, my brain's kind of, I think I have it flipped, but those with high triglyceride levels are 43% more likely to be. How do you interpret with the top third and the bottom third? I'm actually.
Well, you could say then that the top third or the top tertile of triglyceride levels that had as a group they had 43% greater risk of coronary heart disease compared to the bottom third.
Okay.
Yeah. And so, yeah, so that's there. You can see for men, the relationship was even stronger, 51%. Women, that one was, for women, you'll note it actually isn't statistically significant because confidence interval includes 1. So in the fully adjusted data there, adjusted for age, gender, period, smoking, and other established risk factors, which we could look up, but basically they're trying to isolate triglycerides and find out what the effect of triglycerides is or are, holding all those other things constant or removing those other factors as possible influences, because age, gender, I'm not actually sure what they're saying for period there, smoking, those are all risk factors for coronary heart disease, so they're statistically adjusting for those. And you still see that it's, for men particularly, they've got a 50% increased risk, and for women, there's probably an increase. It might be of an issue with sample size. If you had a larger sample, our confidence interval would get smaller. And then for the Epic Norfolk study, just looking at it, it's actually, what do we see different for the Epic Norfolk study? Is the message the same or is it different?
It looks like the numbers didn't change between the adjusted smoking when they add smoking.
Mm-hmm. Yeah, there's that. What I'm noticing, thanks for that, Palmer, what do you notice as far as men versus women?
For this one, it looks like women have a higher percent. They're at 88% more likely than the men are just at 33%.
Yeah, so it's sort of switched around. For whatever reason, the Reykjavik study, it showed that men with higher triglycerides were at elevated risk for coronary heart disease. In the Epic Norfolk study, the men were, but the women, and all those in the Epic Norfolk in the fully adjusted models were statistically significant, but women had a higher risk with the high triglycerides even compared to men. So I don't know what's going on there, but that's what the data are showing us. So thanks for those of you who jumped in. So again, we're making those connections between clinical values and disease outcomes. Okay, so we can measure triglycerides. They're an easy blood test to do. How high is too high? And it's studies like this that help inform clinicians so that they say, okay, yeah, if it's over, I think 150 milligrams per deciliter, we don't have the specific categories, but it's making the case that those who have high triglycerides are at elevated risk for coronary heart disease. Again, epidemiology informing, guiding clinical medicine, which I find exciting. Another one, gout and uric acid. Just a little bit of a review, depending on your background, what gout is. Signs and symptoms of gout almost always occur suddenly. Intense joint pain, usually large joints, often the joint of your big toe, but it can occur in other joints. So there's pain, there's discomfort. Sometimes it subsides and then it gets worse, inflammation, redness, and so forth. So it can have a significant impact on people's quality of life, their movement, their ability to get up and do what they want to do. So here we go. Looking at gout. So this is the cumulative incidence of gout in percent on the y-axis. And so at the baseline, at the starting point, no one has gout. And they're following people for 5 years. And they're measuring urate, which then is the nitrogenous compound that they measure in the blood in terms of milligrams per deciliter. People whose urate levels are less than 7, you can see that the cumulative incidence of gout, even after 5 years, is very close to 0. If it's from 7 to 8.9, it increases, but not nearly as high as if it's greater than 9. Okay, I don't think we saved it. I don't think I saved it. No, I didn't. But when we were looking at uric acid earlier on there, so it's, again, these types of relationships. Clearly, something over 9 puts you at way elevated risk for gout compared to even below 9. Below 9, relatively small risk. If it's higher than 9, bang, over time, by 5 years, over 20% of the people had gout. So again, that's going to inform what a clinician will say in terms of gout, whether, and there are drugs for gout, whether or not you need a drug to take your uric acid, your urate levels down. And it's the decision as to when to do that, at what level, is going to be based on data like this. Okay, making sense? I've got a couple slides yet, but we're not quite wrapped up. So the role of epidemiology in clinical medicine. I'm just going to read this and then talk to a little bit more. So as I've been emphasizing, epidemiology researches the associations between body measurements, clinical measurements, whether it be BMI, blood pressure, blood glucose, uric acid, triglycerides, cholesterol, LDL cholesterol, HDL cholesterol, thyroid hormone, and you could go on and on. Anything that is tested for in a blood test, anything that's measured. Again, we're not talking about the presence or absence of a virus or a bacteria. Those ones are pretty clear cut. But much of clinical medicine isn't talking about, oh, do they have the virus? Do they have the bacteria? Do they have the protozoan? Yes, there are infectious diseases out there, but much of clinical medicine is based on, as I say, these variables where we all have a certain amount and we need to figure out what's too much or what's too little. And that's what epidemiology, that's what public health does. It helps identify the cut points that define the diseases, like we looked at back here last week here when you looked up and found out, okay, what is the cut point? What is the level for HDL cholesterol or LDL cholesterol or triglycerides? All these values come from epidemiology. So these cut points, these values at which a person is said to have a disease, change with time. And that's where it gets very interesting. Let's look at a paper here. And I'm saying, okay, what on earth? It was working previously, and I might be in slight trouble here, just a sec. Okay, they've taken it away. I will have to look that up and see if I have saved a copy of it. My link had been working there. Okay, so I will come back on Thursday with that. Basically what this paper does is look at how blood pressure guidelines have changed over time and what that does in terms of how many people have high blood pressure, have hypertension. So there's some interesting things to talk about there. A next thing I want to talk about, a couple of years ago, and it worked out perfectly. So in fall of 2017, I was teaching epidemiology class. We were talking about blood pressure, and what do you know? New blood pressure guidelines came out. Let me just make sure that you're. Yeah, new blood pressure guidelines came out literally as we were talking about that topic in this class. So it's been just over 2 years, 2.5 years, fall of 2017. And so what I want to do is for you to, I'll just read through it briefly and then take a listen to a discussion between some of the cardiologists who were involved in formulating these blood pressure guidelines, just so you get a sense as to how those decisions are made. So high blood pressure should be treated earlier with lifestyle change in some patients with medication at 130/80 rather than 140/90. Okay, prior to these guidelines, treatment wouldn't have actually kicked in until 140/90, and they looked at the data and said, no, we've got to start treating people at 130/80 based on American College of Cardiology, American Heart Association guidelines. These were the first set of guidelines since 2003. So basically what happens is they set up a committee, they review the evidence, they look at the papers, and then they come up with a clinical consensus. Okay, how are we going to define high blood pressure or whatever issue that we're looking at? The new blood pressure guidelines: normal less than 120/80, elevated systolic between 120 and 129, and diastolic less than 80. Then you get into stage 1, stage 2, hypertensive crisis, and so forth. So I'm going to play this discussion here. And if this is working properly, you should be able to hear what these guys are saying. Are you hearing it? Can I see a nod? Emily, are you hearing this? No? No one's here. Okay, okay. Then I will, let's see. Let me try something else. Just a sec here. Just a sec, just a sec. I'm going to try opening it on YouTube and then sharing that screen, if I can. Are you seeing that now? Hearing it? Okay, I'll start it once more. So 7 minutes of these guys talking about blood pressure.
Dr. Schaefer, we can't hear it still.
And was anyone hearing it? Let me try again. So thanks for jumping in. Okay, so I'm sharing this screen. No hearing? Okay, well, I've got, can you see the closed captions? Okay, I'll start it once more and just follow along with the closed captions and then we'll talk about it a little bit. Or I'll stop it as needed. Sorry about that, I don't know what's going on. So did you catch that? Can you hear me? So did you catch that? When their blood pressure, let's just listen to that once more. Yeah, 130 to 139 for the systolic and diastolic 80 to 89. You heard him say they're already at double the risk for heart attack. That would be looking at graphs of data similar to what we have here. And so they're looking at it and saying, hey, you're above 130, you're at 135 for systolic. There's higher risk, there's elevated risk there. So if we can treat it, if we can bring that level down through lifestyle, through drugs, that's going to reduce the risk of heart disease. And that's, of course, that's what the goal is. Okay, and that's the issue that I'm going to bring to you in the paper that I couldn't access. If we change the definition of hypertension, and it used to be, oh, higher than 130, now if it's higher than 120, suddenly you went to bed and you didn't have high blood pressure, you wake up and you have high blood pressure. And so suddenly there's more need for clinicians to manage it. There might be more need for lifestyle people to help people become healthy, or there's more need for pharmacists. So when you move that definition, you're going to capture more people. Now, the motivation is good. The motivation is, hey, if we can do something about it, we can reduce the risk of heart disease, we can reduce the risk of stroke, but there are consequences of changing a definition, just like we talked about with the COVID-19 definition, the Wuhan virus in China, so they're changing the definition. Now that was for an infectious disease, but still changing a definition will change the number of people that meet the criteria, and there are clinical implications to it. So that's a very important point. Okay, do you understand what he's getting there? Elderly people, their systolic is high, their diastolic is low. Okay, so the low number, the over number is low, and it's not as though that cardiologists and clinicians can just fine tune. Oh, your systolic is your diastolic. Your systolic when the heart is contraction. Oh, that one's too high. So maybe we're talking about someone who has a blood pressure of 160 over 80 or 160 over 70. The top number is really high. The bottom number is not high or maybe even a little bit low. Should we worry about the 160? Because when you low, it's not as though you can just dial down the 160 without the diastolic also going down. Okay, so is there a risk if we, in our attempts to lower the top number, the systolic number, is there a risk that we'll move everything too low and that we'll get a diastolic number that is too low? And so he's going to answer that question. So what's the issue with falls and fractures when we're talking about blood pressure? Someone want to jump in? No? Hannah, do you have any insights on what the relationship between falls and fractures and blood pressure might be?
Well, typically people with low blood pressure have a higher risk of falling due to just, they call it like when you get up and down, it's like you're super lightheaded. So elderly have a large problem with that, and then they can fall over and fractures. If you have low blood pressure, the healing process is not as quick. It just kind of leads to multiple things.
Yeah. So the issue, you're sitting down, if your blood pressure is low, you stand up, you get dizzy, you fall over. And so that's the concern, is the diastolic blood pressure too low? Is that going to increase the risk of fainting and that thus fractures? So that's the concern. Well, if we take the systolic down, is that going to put the diastolic down too low, and then more fractures and hip fractures, which is a whole nother level of risk? Okay, so you caught that. Masked hypertension, people who are lower at the doctor's office, and so when their blood pressure cuff is on, they're relaxed, they're chilling, and that's an abnormally low reading compared to what they have consistently at home. And so that prevents the clinician from identifying it, and they are at elevated risk. As opposed to white coat hypertension, which, yeah, your blood pressure shoots up temporarily, but there's no association between white coat hypertension, the shoot up in blood pressure just because the person's a little nervous or uncomfortable in the doctor's office. That isn't associated with higher risks of heart disease just because it's so temporary. It's not a continuing burden on the cardiovascular system. Okay. So that's then it gives you perspective from cardiologists, people who are actually in there writing the guidelines. So I find that interesting. I also, you can't help but notice we're looking at 3 older white men. They're the senior researchers, they're the senior cardiologists, and that reflects, you know, what was happening in med schools in the 1960s and 1970s. We'd anticipate that in future there'll be more diversity in terms of males, females, ethnic backgrounds, that type of thing. But it's sort of striking. They look like they're all probably close to 70 or more than that. So last thing I want to do is talk through with you the assignment, because you're going to be digging into this stuff. So I'm going to find it, and just a sec here. So I'm going to Moodle, and then I'll share my screen with you momentarily. So in Moodle for last week, March 16 to March 22, there's assignment 6. I had called it assignment 7, but it turns out it's actually assignment 6. And it's called Blood Pressure Guidelines. So let me share my screen again. Here we go. So now what you're looking at is the paper that these guys were talking about. So Paul Welton, he was one of the people, I think he was the one in the middle that we just heard from. So this is the guidelines for prevention, detection, evaluation, and management of high blood pressure in adults. And this document is, I believe, 400 and some pages long. No, you don't need to read it all. Okay, but this then is the clinical document, and this is a classic example of why I don't like to use a textbook, why I'd sooner have you see the real thing that clinicians are looking at from the journal rather than someone else's synthesis of it. Yeah, there's another name, Kim Williams. I believe he was the guy on our right of our screen. So those were the authors of this document. and you can see the task force. So it goes through here, page after page. And your assignment, which I will now, then I'll show you as well. So if I, here we go. So now I'm sharing the assignment. And my generosity to you is that I tell you which page to look at. Okay, so you do not need to read the whole document. If you're thinking about becoming a cardiologist, you might want to do a scan through it. But so what I do is I'm basically leading you through what I thought were the key points. I scanned through the whole thing. I did not read the whole thing word for word. So for example, in the preamble, read pages 6 to 8 and summarize in a short paragraph the purpose of these guidelines, how they're formulated. Look at table 1 on page 9, describe the meaning and function of these color codes for class of recommendation and levels of evidence. You'll dig into that, page 25, page 26, page 40, and so forth. So I'm leading you through it and asking you questions about specific parts of it. Okay, I am counting this assignment as individual or groups of 2. Some people like to work with a partner. Given our situation here, it might be more easy for you to do it on your own. But if you want to work even at a distance with a partner, make sure that you both look through the questions and understand all the questions and that it's a joint effort. But if you want to do it that way, that's also fine with me. Okay, and then this then is our assignment due for next Tuesday. Okay, Tuesday, March 31st. You should have turned in your assignment on the salmonella in Kenya. I'll be looking at those soon. Okay, are there any questions then about the assignment? Anything that we've talked about? You're all looking alert, and at least those that I can see. Okay, so then we can talk on Thursday if you wish, or even on next Tuesday, the day it's due, if there are any questions about the assignment. But I hope you find it interesting, and I think this is the most effective thing I can do, is to actually present you with these types of papers. And there'd be other papers, similar papers about heart attacks and about diabetes. This one just happens to be looking specifically at blood pressure, but so for pretty much for any disease that's related to a clinical measure, there are going to be papers like this. There are going to be guidelines that have been put together by review committees of experts, which basically describes then to the clinician or recommends to the clinician how they treat the diseases at various levels. And you'll see that in great detail then for high blood pressure in this example. Okay, so that's all I have to say. Feel free to send me emails if you're having any difficulties. I have recorded this and I will put it up. I think most everyone signed in. I do get a log of who signed in, so I will keep up with our attendance for extra credit purposes with perhaps a little bit of flexibility, but now that we're rolling with Zoom and distance classes, hopefully you can sign in and maintain your perfect or near perfect attendance as well. So I'm going to sign out and wish you all a good day, and we'll check in on Thursday then. Okay? Bye.